the permission of the President of the Nation, it's our great pleasure to welcome Professor Pawan Sultania to our this Nation regular webinar forum. He doesn't need any extra introduction. He is the second president of the Nepalese Society of Neurosurgeons. First founding president was Professor Demerit, and following he is the second past president of the Nepalese Society of Neurosurgery, and he's been a guardian to all of us. And he worked at National NAMS. He was a professor and chairman of the National Neurosurgery Referral Center at Bir Hospital. Then after leaving Bir Hospital, he joined Nepal Medical College, and he's the professor and chairperson of the Department of Neurosurgery there. And today he is going to talk on a very relevant topic. We should never forget our past so that we will not commit the same mistake in the future. So he is going to talk on past prospect of neurosurgery in Nepal. Please, over to you, sir.
Thank you, Mohan, for a nice introduction, and good evening, everybody. And today I have been asked by the NESON, so I am very much grateful to the NESON for providing me the platform to share my views with all the audience. And I'm also thankful to the organizing persons, especially Amit Thapa, who is the leading academic chair of the academic in the nation, and he is working very hard to organize it very regularly. So it will continue. Certainly, previously it was once a month. Now it is having about 8 presentations every month. So that is a great achievements we are having, but I don't know how long we shall go. So today I am going to talk about the prospect of neurosurgery in Nepal. And in these connections, I would also try to highlight the past, present, and future of the neurosurgery in Nepal. The reason behind
Prakashi, yo chalen ta?
Screen ma click गर्नुस् न एकताका
केमा
कर्सर लिएर स्क्रिनमा क्लिक गर्नुस्
Okay.
The reason behind is that just before the lockdown, 3 or 4 neurosurgeons, I mean young neurosurgeons, full of the knowledge, just passed out, bustling with the knowledge and their experience, shared their views and showed some disappointment and dissatisfaction about the neurosurgical career in Nepal. And in that concept, but I'm seeing a lot of the opportunities. Of course, challenges are there, but a lot of the opportunities available in the Nepal. But it is only thing that we have to tailor our coat according to the cloth. So as we are in Nepal, certainly we have to tailor according to that. Of course, we have a very good knowledge, experience, and equipments and instruments we saw in the institute where we were graduated, but certainly we have to change our attitude according to availability in the Nepal, and we shall succeed very happily. And it is a photograph of the Mr. Bill Roth. Those who have done their post-graduation in the general surgery, they know very well. The Bill Roth was the persons who designed the operations for the gastrectomy, and that was a must for everybody, at least in my time of the MS. But without knowing the Bill Roth operations, probably it was difficult to get through. So Bill Roth is there, and he wrote about 2.5 centuries before that only the man who knows exactly the art and science of the past and present is competent to aid in its progress in the future. So it is 250 years before, and still it stands true. So we have to know our condition in the Nepal. Neurosurgery became a fraternity very late. Before that, it was the surgery, and it is a part of the surgery. So I would like to just say about 4,000 years before, around 4,000 years before, the first documented paper we have, it is the Edwin Smith surgical papyrus, and that is from the Egypt, not from the Europe, not from the States or USA. It is from the Egypt. The first paper was there. So I'm trying to say over there, it started in our part of the world and gradually expand in the other parts of the world. But that is not a question that we were the first. We have to develop this science as a whole. And Hippocrates from Greece is already known as father of the medicines, and that is about 2004 years before, and he totally devoted his life for the development of this science that is known to us. Now I shall just introduce few of the neurosurgical elegant people. Mr. Bergman from the German, and he wrote the first book of the nervous system in 1870. And since then, the nervous system, but this neurosurgery was not, it is the nervous system that he wrote about. Brocage area, we all know. He was an anatomist from Paris and who described the Brocage area. And as a surgeon, we know how important the Brocage area is for us, because if any patient is having a lesion in the Brocage area, we always try to save it or preserve it, because that is important for the life. Likewise, the McMinn is also very known, elegant, and he was the first one who excised the meningioma in 1879, and subsequently he's the same person who did the first laminectomy in 1883. And likewise, the Victor Hoseley is recent one, and that is in the 1888, and that he worked on the epilepsy, and beside that he has many credentials in his part. But real development of the neurosurgery took place after the Harvey Cushing, who was the first one who devoted only for the neurosurgery. He was not doing anything else, but he and the Walter Dandy were, contemporary and good friends, and both of them had a training from the Victor Hoseley in England, and then they shifted to the States to develop it. But his contribution to the neurosurgery is unforgettable. These are the few just epochs of the neurosurgery, and which I copied from the Amit presentation somewhere. So, but I have kept it very little. He has a very lot, 8 to 10 pages he has done that. So the Warren, we know every anesthesia in 1846 and first anesthesia, how it was done. Now it is a different shape. And likewise, the Semmelweis in 1847, he gave the concept of the aseptics, like the Theodore about the microscope in 1857, and Lister, very famous person, who gave the concept of the antisepsis in 1867, and that we are still following. Likewise, the Röntgen invented the X-ray in 1895, and on that principle, the CT scan is there, and we are very much using it, and that is one of the most useful tool we have. Likewise, Safar gave a concept of the ICU in 1950, and following that, the Janet's and Teasdale gave the concept of the GCS in 1971. And at that time, to assess the level of the consciousness was very, very difficult. And this GCS system became so popular, and nowadays for consciousness level in any patients, this GCS is, every students mugged up the GCS and it is being done, but previously it was only for the head injury that they promoted it or they proposed it. Like the Hounsfield was the first one who gave the concept of the CT scan, rather still the Hounsfield unit, we all are aware of that. And Demerit was for the MRI in 1977. And these are the two great tools in our hand, the CT scan and MRI, which has really gave, for the prognosis and the diagnosis. Now I shall speak. Few slides are there for the neurosurgery in Nepal, and in neurosurgery in Nepal is also not a recent one. It is already about 60 years. So 60 years has already been spent for the development of the neurosurgery in Nepal, but the development is slow. That is the only part, and because of our various reasons. Professor Gongol, after his post-graduation in the surgery and did the craniotomy in 1962, and he was a resident of Professor Gajendra Singh in Bombay, and while he was doing his thesis, he did his thesis on the hydrocephalus, and at that time he developed the interest in the neurosurgery, and immediately after coming back, he started the craniotomy with a very primitive carpentry tools, but he started, and since then it keeps on increasing, that I will show you. And Damodar Parajuli is the another well-trained neurosurgeon, and he came back from the UK after his training, and he had his training for 4 years around, and in 1978 he joined the army hospital and he started his work over there. This is the Beer Hospital. All are very much known to us. And in 1980, the ward for the neurosurgery was started. Before that, it was a common ward sharing with the general surgery. But in 1980, we got a ward for the neurosurgery, and it was Professor Gangol who was looking after. And we can see some figures over there, and the OT, because number of the OT was very few. Hence, it was a special OT, which he used to do the neurosurgery after 2 p.m. Till 2 p.m., the same OT was being shared by the general surgeons. After 2 p.m. only, it could start the neurosurgery. That is the way he struggled to establish the neurosurgery in Nepal. And the army hospital also started doing the work, but it was, of course, not very promising at that time. And I must must say the Professor Mathai. He was the first Indian trained neurosurgeon. He was trained by Professor B. Ramamurthy in Chennai, and he was the first one who was Indian trained neurosurgeon, and he started helping us from 1980 onwards. He came many times to Nepal, and he used to stay for 3 months, 4 months at a stretch in Nepal, and helped us to develop the neurosurgery. And not only that, his first student was Professor A.K. Banerjee. A.K. Banerjee, who after his training in the Chennai, came back to the All India Institute, and he established the neurosurgery in Delhi. And these are the basic instruments with which the Professor Gangol was playing with. You just see that the myelography was there, carotid angiography was there, ventriculography was the only way that we could space occupying lesions in the brain, and the blood transfusion was very primitive, that person to person was some sort of that. There was no blood bank, and there was no, these bags were not available. Electrolytes was not there. Anesthesia was the sharing type. ICU service was not there. Instruments I already talked about. And so certainly with all these odds, the mortality and morbidity has to be very high. And it was, infection was so common because it was, the patient was used to put in the general ward or general surgical ward rather than a special ward. But some sort of the publications started in the JNMA and Journal of the Society of Surgeons of Nepal. We can see, this is a photograph, it shows the demography. The population of the 30 million, just we crossed the 30 million populations about few weeks ago, and now it is about 10-15,000 more than the 30 million populations. and it was reported about a month ago, I think. And the per capita income has increased. When I joined here, it was around 450 or 500. Now it has doubled, around 1050 per capita income. And the area, we have acquired another 360 square kilometer in last 1 month, so which I have added over there. And the health budget was about 7% or 6% throughout the, but because of the corona, this time it has been increased to the 10%. This is the most important slide for today's concern, that the prospect for the neurosurgeons in Nepal, and we can see with the figures what is the situations worldwide and what is the situation in Nepal. So worldwide, the ratio of the neurosurgeon 1 into 230 population for one neurosurgeon. Europe is about 1 into 120 lakhs, 120,000, and USA it is 65,580. In Nepal, it is about, because we are about 90, so it comes about 350,000 per neurosurgeons. That is the figure that we are seeing. Currently, it is 90 plus neurosurgeons already registered in our society. And so, but with the population cater, if we calculate with the USA requirement, then probably we need about 400 neurosurgeons. So there is a lot of the deficit among number of the neurosurgeons. And what I'm seeing, 2 years before, there was 80 plus neurosurgeons. Now it is 90 plus. So every year, more or less, we are adding 5 to 10 neurosurgeons every year. So if we calculate by that, it will take at least 36 years to fulfill our present requirement. So can we wait? Can a craniotomy or a brain tumor or a intracranial hematomas should wait for the 36 years? This is the scenario over here. And on top of that, I'm just saying, out of the 90, 80% of the neurosurgeons are very much in the valley itself. If you go beyond the Banepa, if you go beyond the Nagdunga, probably the scenario changes quite. So in Kathmandu, the one neurosurgeon has a population, has to cater about 60,000 of the population. So that is better than the USA, that is in the valley itself. Whereas if you go outside that, so 20% neurosurgeons are scattered in whole of the Nepal, and they have to cater about 13 lakhs populations one neurosurgeon has to cater. So here I want to point out that so many of the requirement is there. So there is no dearth of the patients. And the development of a career is only by two things. Either categorically, if you see, technical advancement should be there, or one should have a vast experience. So certainly we can have to compromise a little bit for the technical advancement, but we can have a number of the patients, so that experience matters a lot. Many of the neurosurgeons in Japan hardly get opportunity to operate upon, but here a lot of opportunities there. So we don't have to be frustrated at all, but we have to make the need, how can we cater this population. This is the list of the neurosurgeons. How did it start? I have not put the Professor Gangol's name here because I already mentioned him. So full-time neurosurgeon was our late Professor Devkota. And he is, after his training, started in 1989 in Veer Hospital, and since then he worked there. And subsequently he shifted to the Ninas in 2007 or 2008 probably. And Achut Sharma at the same time joined the army, and he was also trained in UK, and he is still continuing his service. Lakhanlal Shah was the another one who joined in 1994 in the 40 years, and subsequently left the neurosurgery, and now he is practicing general surgery. Myself came in 1996, and followed by the Basant, Sushil, and Gopal joined us. Although Gopal was working in the neurosurgery for 8 to 10 years, that way he was much more experience than me because he was working there, but he came back after his training in the 2000. So I have put his name over there, and followed by the Krishna Sharma and the Mohan, and the Prakash Beast is there into 2005. And I'm sorry to say, Balkrishna Thapa was the one who started the neurosurgery outside the valley. He was the first one. He was doing quite well, but somehow we lost him, and I'm sorry for that. And currently we have a 90+ neurosurgeons scattered throughout the country. These are the glimpses of the hospitals where the neurosurgery service is around the clock running. The Beer Hospital 1980, and Army Hospital also 1980, and TUTH 1995. And currently in Valley, there are 20 hospitals which are rendering the neurosurgical service, and in the private sector, in the semi-government sector, like the Kathmandu Medical College, Nepal Medical College, Norvik, Medicity, Bayodhya. So many hospitals are providing this service. Annapurna, Ninaj, likewise. And outside Valley, if I remember, nearly about 25 hospitals would be there, and which is providing a neurosurgical service, and more it is dense in the Biratnagar and the Pokhara. In the rest of the cities, it is very, very scarce in number. So it is, but it has become available outside the valley, and that is a great news. Not only that, the Karnali, the Jumla, the Karnali Institute or the Sudur Paschim Institute has started the neurosurgical service, and just few weeks ago we heard Neelam his webinar on the laminectomy, and he has already done about about 10-20 surgeries. So it is a great achievement that the very remote area has already having the neurosurgical service, and operations are being done. So everything is possible if there is a will. And now, I think less than 10% of the patients going abroad for the neurosurgery services, and especially it is for the fashion, and I say a little bit of them wants to show their wealthiness or their well-off, therefore they go. Otherwise, all the services are available in the Nepal nearly, or those few are not there, they have to be referred. This slide depicts how much of the neuroimaging equipments we have. So a scanner, MRI, these are PET CT, still we have 2, and TCD has numbering, and gamma scan is 3, but none is functioning. It is there and it is hanging on the stand, but it is not functioning because it is very difficult to achieve the obtain the isotope. And as far as the latest, technological developments, latest equipments are there. Just neuronavigations are there, stereotactic endoscopy, periopsity, and neurophysiology is only in one institute for operative neurophysiology available, and probably may have done in the other, but I don't know. And the another is the microscope and bipolar. Majority of the hospital do have, but the number of the basement or location of these are very few, and there is a lot of the gap. Suppose if it is one is available in the Biratnagar, the another is available in the Birigan. So a distance of about 400 kilometers. And in neurosurgery, majority of the patients enter as emergency patient, either be a stroke or a tumor rundown patient, or a head injury or a spinal injury. So we can imagine, so until unless it becomes available at the door, which we must do, then certainly that will be. So decentralization of these is very important. That is what I'm trying to emphasize upon. These are the types of the procedures which we are doing day in, day and night. And here I would like to say that the functional neurosurgery is very important. So that it is being done. The DBS, epilepsy, benign essential tremor, it is being done. MBD and pain spacit is doing at other, but these three, I mean, yes, and EB it is done by Basan, and epilepsy surgery is done by many. And it is a very good news that we are doing quite frequently now the coiling, embolizations, and stenting. And Nina has obtained a new machine, and which I had an opportunity to go 2 days before there for some reasons for the NESON. And then Dr. Madhudev Kota was showing me the new machine, and it is a 2-panel machine, and that was quite impressive. And chemo and radiotherapy is still the cobalt one, but I'm hearing there are 2 new machines has come, one in the Sudeep Center, one in the Anjani Center, and that is better than the current one. So waiting time was too many months in the NAMS when I was working over there. But now it has certainly decreased dramatically, and rather now we are feeling that there is a dearth of patients in the Kathmandu Valley, and we are not getting the adequate number of the patients. So certainly that is the situation in the Kathmandu Valley. So waiting time has decreased. And certainly one thing I would like to highlight over there, that the neurosurgery, number of the patients in the neuroscience has to, because nervous tissue constitutes about 2% of the only body weight. So certainly lesion of this nervous tissue will come to us. So certainly in the medicine, in pulmonology, or in the hepatology, the number of patients has to be high, but our patients are very sensitive and very demanding. So that is the criteria in the neurosurgery, and which we have to fulfill their requirement. Am I clear or going very fast?
No, it's perfect, sir. Perfect.
Thank you.
Everybody is really spellbound with your presentation. I'm seriously saying it.
Thank you.
So informative. Please carry on.
And these are the various procedures which we do for the spinal surgery. That is already there. And I am trained, and I know about the leakage and interspinous fixations. And now certainly a screw plate has become a very common procedure. It is being done by many of the neurosurgeons, but I am not trained on that. So certainly I appreciate and salute those who are doing that. And if you ask me, why don't you start yourself? I am not interested to start anything new now onwards. But is beside me, so he does it for me. Thank you. It is said that without anesthesia, it is very difficult for the surgery or surgeon to move on. So it is very important. And I must salute this gentleman, Visarad Manshrestha. He is still working in the Kathmandu Medical College. Probably he left the job in this Baisakh, as far as I know. So just he got, otherwise till now he was working over there. And he was the full-time anesthesiologist, neuroanesthesiologist in the Nepal. After his training in UK, he came here and he started and doing that. And following that, the Madhav Gautam is working as Nina, and MB Chand probably he is not in his practice. These are the two who did the neurosurgery, full-time neuroanesthesia, and recently many are doing that. And they are doing both the cranial and the spinal procedure. There is no distinctions for that. And avic craniotomy is also being done. But still the anesthesia is sharing. Full-time neuroanesthesia and neuroanesthesiologist is still very rare to see in our scenario. And the neuro ICU is also very few. And mostly the ICUs are sharing. So certainly that constrain your output when you have to share with the others what it is there. And now it is a good news that so many of the intensivists are there. So previously we used to do that in the ICU. Now it is the intensivists are doing a lot of the things. Now I don't have to go very frequently to the home ICU. They do it. They inform me that this has been done and they are doing a perfect work. So that is a good news for us. And other sciences are certainly most of the sciences or supporting branches are the sharing, like the pathology, ophthalmology, rhinology, and neurophysiology also is the sharing one, and endocrinology also. But now the endocrinologists are available, but previously we had to manipulate after the pituitary surgery, we used to manipulate the hormones, but now the endocrinologists are there to help us. And these are the three nurses who had the special training in the neuroscience, and after coming back, they were the one who worked full-time in the neurosurgery, and subsequently they trained many, and now there are so many nurses are there who are already helping us, without which probably we cannot move any further. And a little bit of that, these two faces are very much known. One is the Prakash, is heading the neurosurgery in Veer Hospital, or rather NAMS, and the Maya is working with us after his completion at at IOM, and MCS program is being run in the 4 of the hospital, but the intake was a little bit more, but now the intake has reduced. It was 8 to 10, now it has reduced because the teachers are less, or there's some more strict laws by the university, so that is hindering teaching program. And it takes about 6 to 8 after their completion, joining every year. So 6 to 8 are there. And so I already told about 10 we are having, and there is still loss of the discrimination between the requirement and the supply. And CPD point is there. We are also going to get some CPD point out of this audience, and that academic program is very important for us, because the youngster has to accumulate 100 points in 5 years to renew their license. Otherwise, it would be difficult. Probably in next 5 years, I won't be practicing, so probably I don't need these points. And this is our society and the conference. So it was the first SAR conference was organized, and I was the general secretary in 1999, and Professor Devkota was the president of that. And but that was under the banner of the Nepalese Society of the Clinical Neurosciences, and we have a certain very handsome amount under the banner of the NSCN, and we are trying to retrieve it. I don't know whether we succeed or not, but that is very handsome. And if that amount comes to our society, and that will, we have to invest somewhere in a very positive function. And 5th SAR conference was, I was the chairperson, and then we did that. And spine chapter was started by Krishna in 2016, and subsequently neurovascular was started by 2018, this chapter by the Gopal Raman Sarma. Here I would like to highlight few points about the NESON. The NESON is, till now, it is very much active in the academic activities. It has not been able, it should be, but it has not been able to address the needs of the neurosurgeons, because it is still under the control of the Ministry of the Health and the Nepal Medical Council. So that, and we have been already proposing and asking for the rights so that we can control at least one, because they have to look after, there are 30 sister concern under the Nepal Medical Association, and they are looking for our rights. So anything, if there is some problem as happened in last few weeks, so we have to go to the NMA. NMA has to proceed further for any action, otherwise the nation can only propose. So that way, but we have to make it more powerful so that we don't have to depend on anybody. And Mohan is a publication academic activist there, because he is the most enthusiastic and very much interested in that. So he started our Journal of the Neuroscience, and he did that. And now he has already given the, responsibility to Amit. Amit is doing now. So this activity is also going on equally, but certainly with the virtual meeting, the certainly how much of the print matters that we have to take into the account. Now I shall have a few slides about the futures requirement of the country, and the youngster has to do a lot to in the future, in the stimulate them to do that in the future. On the right side, there are three pictures which shows us that this is the situation that patient is being still carried, and they have to travel 1 day, 2 day to reach. So certainly the neurosurgical service has to be provided. They have to be addressed. How can we address that is a very difficult task, but certainly we can do that. It has to be gradually, we have to think on that. So that is the one thing. And the another thing I will see over there, that in the functional neurosurgery, the DBS, stenting, chemotherapy should be made available. And the last para, the majority of the services are available only in Valley itself. So certainly the patients do not become attracted to this until unless we decentralize these services also outside. Somebody of us has to take the responsibility to carry it outside. So what is going to the in future task is there. So Nepal has 3 regions, and we can see. So Tarai is very easily connected by the surface route, where no problem is there. Mountainous part is very difficult to connect. So if we go for the telemedicine, this is the one thing that we can connect them, provide them the services, and certainly they will be very happy. And that way the required patients, as in the head injury, only 5 to 7% needs surgery. 90 to 93% can be treated without surgery. So if there is some help that we can extend, that we can use the telemedicines to help these patients, so that our horizon increase. So these are the few equipments which is still not available in the country, and which our residents needs to know, and certainly the benefit should go to the patients also, like the robotic surgery, radio surgery, stem cells, gene. And this is a new equipments which I just came to know a few weeks ago, that is called exoscope. The picture is on the right side, and it is nothing. It is a, I don't say the replacement, but certainly the size is very small and the picture is very bright, and we have to operate on by seeing on the screen, and it can go into the very corner of the our operation site. So this is the advantage. And last time I got it when Italian neurosurgeons shared his experience in one of the webinar of a case of about 100 or 150 cases he has already done by the exoscope. So this is the new. And Basant Misra told at that time that the company has brought the equipments to the Hinduja hospital, and they stationed it for 2 weeks over there, and he did not get, he was not very happy with this, because he has to learn this technique. So, and probably Hinduja did not buy. So by this now, probably in our neighboring countries, this is still not available. But certainly this is one of the future requirement, and it has made the life very easy. And these are the various, I mean, fictions are there. So what is going to happen in the 21st century? So these are the neuromodulation. Neuromodulations is for a patient. So there is some, if some modulation is done in the neurons, the patient's certainly treatment will be quite different, and that is for the memory enhancement. Hypothalamic stimulation, it is already in the vogue. hypothalamic stimulation under clinical trial which suppresses calorie intake, thereby control the obesity and its consequences. So it is already in the, probably it has started. And likewise, the memory enhancement for forgetfulness in elderly and pathological region of the brain. So it is also possible. It is in the, we have to think on that, and we have to make according. Likewise, the neuro enhancement. So these are the upper two bullets are showing that this is the way, or these are the gadgets which is used to develop the neuro enhancement. It is like putting a pen drive in the brain itself. Memory gets increased. Application of these are for the 3 points which I shall be explaining in the another few slides. Cortical and sensorimotor enhancement, the use of that. We already know about the hearing aid or the retinal prosthesis for the visual improvement. It is already in the practice. So likewise, if we augment the motor cortex, the paralysis can be, or the gesture of the paralysis or the disability can be reduced, and it is already there. People are trying on that. So young neurosurgeons will have to spend time on this also. Like the occipital cortex enhancement stimulations for the vision, and the for memory, hippocampus or cornices are there, and the speech locked-in syndrome is there. It is a lot of the debate was going for this speech augmentation in the last conference. EAN, European Association of Neurology, did the whole of the three days or 5 days conference on virtual meeting, and I attended many of their sessions, and they were talking about this locked-in syndrome. They are not very much, happy about this, and interface with the mobile device for communication. So if there is some sort of the difficulty in articulation, so brain can be, this mobile can put a sound to the patient. Likewise, this is a deep brain and the spinal cord modulations can be done for the, like the many medicines, seizure, schizophrenia, bipolar. Currently, we are prescribing medicines, TDS, PD, something like that, and that is a very much stereotypic form of the prescription. But by this modulations, they are telling that the seizure, how much dose is required, when is required, it can be calculated. A patient will have to take only that much of the dose for that instant. This is possible. And like the optimized dose for a patient at a particular instant in time. Likewise, the vagal nerve stimulations for the seizure control is already known to us. Likewise, the autonomic enhancements can help in case of the heart failure, asthma, pulmonary hypertension, inflammatory conditions, etc., autoimmune disease, it will be there. So these are the things which can be used very easily, but it is in the process of the development. And this is a slide which shows the use of the artificial intelligence very much for the weather predictions is there. Like the agriculture, it is being used. Like in many of things, it is being used. Like the GPS system is again artificial intelligence. So this is being also tried in the neuroscience also. So artificial neural network can help us by the analyzing the data and predict the specific outcome. What can be there? So few patients or few diseases can be diagnosed easily, like the lumbar spinal stenosis, disc herniations, brain tumors, epilepsy, trauma, cerebral vasospasms can be very much, if you read the data in the, they can diagnose patients. And the demerit of the artificial intelligence that sometimes the diagnosis is wrong, which can happen with the human being also. But the problem is there, if the patient is not satisfied, I challenge the misdiagnosis. If they go to the court will penalize them. The machine, if they penalize the machine, there is no achievement. So certainly the human being is very much required for this. That is one. and individualized care of the patient. Certainly, the emotional attachment cannot be by the machine. So emotional attachment is very much required by a human being. So individualized care of the patients cannot be replaced by any of the machine, whatever it is. And this is a training part is there. Victor Horsley was the first one who started. I already talked about. And there is a technical advancement by the Harvey Cushing already known to us. And adaptation, certainly we have to learn these technologies, and many of our youngsters have already practicing. And these are the basic science where the development is already there, but it has to come to our country, the technology, gene and immunotherapy, stem cell implantation. Krishna was very much interested in following a stem cell implantation, but not able to do anything. And then intersection, these are the germ cells, the ectoderms and endoderm. So if the vision area is there, if we can put the germ cells, and that may become grow into the neurons and can function. That is what it is being done. And the but everything, because in our country, if this technology comes, it will be very, very costly. We won't be able to avoid it. So we have to, right from the beginning, we have to go for the innovations and improvise the technique that we can be used in our country. For example, I tell, we all heard that somebody in the dam made a fossil oil from the herbals, and he started a generator by that. So he is doing that. The cost of a sanitizer may be 5 lakhs rupees. He produced it already for the 6,000 rupees. So that is there. Mahavir Pune is another one he is doing. So we can do also. So where the neurosurgery would be in the next 40 years, this is a slide for that. So I have divided in two parts, the traumatic part. So intervention for the traumatic brain injury and spinal injury will keep on going. And Lingam Safar is very much interested on it. So certainly imaging will be of a better quality, and monitoring will be less invasive, and surgical tools of a better quality, and the cranial decompression will continue, and the spinal fixations and repair will increase in number to maintain the mobility. They will have a better life than whatever they are having right now. And the non-traumatic, like the gene and immunotherapy is there. Micro repair or the Parkinson's disease, Alzheimer's, tumors. So some sort of the neuromodulations is expected over there, and to correct the functional deficit again, is the same thing. So it is doing there, and it is a brainchild of the Jeffrey. So these are the social activities, but what we can't, so till now, the cadaveric transplant is being used for the kidney and the others. But what I wanted to mean, in the neuroscience, there is one place where we can use the cadaveric transplant, but I have not read it. So that is one, at least in the peripheral nerve repair, where we are sort of the length of the nerves. So there we can we use that? That is one plan, and Amit can be a better person to comment on that. So in conclusion, I would like to conclude this session that the past success do not guarantee future success. Hence, innovations improvise for the treatment of disability and the functional neurosurgery is the challenge of present and mainstay of the future for the neurosurgery. So we have to focus on the disability and the functional neurosurgery. Likewise, it must be decentralization. In our country, it must be available. Then only people can certainly appreciate the neurosurgery. If it is not available, then certainly it cannot be heard. Thank you very much.
Thank you, sir. Thank you, sir. So very energizing presentation. right from the history to modern artificial intelligence, you have covered excellent. You have covered the entire facet of neurosurgery, both internationally and in Nepal. So the forum is now open for discussion. Any questions, comments, please? As Achut sir, Achut sir, would you like to say something? One of the very senior member.
Okay, thank you very much, Dr. Mohan, for letting me to say a few words. First of all, let me thank Dr. Pawan Sultania. He is a friend of mine. I know him very well. And I like to thank him for including Army Hospital in his presentation. I think it is the first time somebody has spelled the name of Dr. Damodar Prasad Parajuli. Let me say a few words about him. Actually, he did his MS from India. Then he went to UK.
Sir, हजुरको मुख अलि देखिए छैन अलिकति मिलाउनु छ हजुरको स्क्रिनमा अनुहार
आउँछ
हाफमा त देखेछ हजुरको फेस
ल कसरी हो त
बेटर अहिले जस्तो गर्नु अहिले राम्रो छ अहिले ठीक छ अहिले ठीक छ
भन्नु कि इंग्लिशमा भन्नु
जे गरे पनि हुन्छ आई थिंक नो फरेनर्स हियर
अब भनेको भन्न सजिलो हुन्छ
सजिलो हुन्छ सबभन्दा पहिला त म पवन डाक्टर साहबलाई एकदम थ्यांक यू भेरी मच हाम्रो आर्मी हस्पिटल पनि इन्क्लुड गर्नु भएकोमा अब धेरै जनालाई हाम्रो पराजुली डाक्टर साहब बारे थाहा छैन होला यङहरु धेरैलाई उहाँ चाहिँ अलिकति म केही शब्दहरु उहाँको बारेमा भनिदिन्छु उहाँ चाहिँ इन्डियाबाट एमएस गर्नुभएको सायद गङ्गल डाक्टर साहब र उहाँको एउटै प्लेस जस्तो लाग्छ कलेज त्यसपछि उहाँले आर्मी जोइन गरिसकेपछि युके जानुभएको युकेमा गएर उहाँले पहिला फेलोशिप गर्नु त्यसपछि उहाँले न्यूरो सर्जरी गरेर 78 मा 78 मा उहाँ एज ए न्यूरो सर्जन आर्मी हस्पिटलमा जोइन गर्नु म चाहिँ त्यसबेला एज ए मेडिकल अफिसर जोइन गरेको थिएँ त्यसकारण उहाँको एक्टिभिटी सुरुदेखि अन्त्यसम्म नै उहाँसँग थिएँ अब उहाँ रिटायर भएपछि मात्रै मैले उहाँको काम लिएको हो म चाहिँ अलि धेरै समयको लागि नै गएको थिएँ युकेमा अब हाम्रो त आर्मीको सिपाही भएको हुनाले मैले फेलोशिप पनि एकदम चाँडै सकेँ मैले यो न्यूरो सर्जरी पनि एकदमै चाँडै सकेँ त्यसकारण म दिएको टाइम 4 वर्ष मलाई दिएको थियो म 2 वर्षमै जम्मै कम्प्लिट गरेर 3 वर्ष पनि नपुग्दै म आएर आर्मीले बोलाएको हुनाले आएर जोइन गरेको त्यसकारण आर्मीमा न्यूरो सर्जरी भइ नै रहेको थियो त्यहाँ आएपछि उहाँले त्यसपछि हामीले आफ्नो गरिरहेकै थियौं अब हाम्रो चाहिँ त धेरै त्यति आजकल चाहिँ म धेरै न्यूरो सर्जरीमा त्यति एक्टिभिटी मेरो छैन अहिले हाम्रो नरेन्द्र भयो अब नरेन्द्र त गइसक्नु भयो त्यो होस् पवनले गरिरहेको छ अरु चीज अहिले चाहिँ मलाई आर्मीले अर्कैतिर काम दिइरहेको छ अहिले म चाहिँ यता नेपाल आर्मी इन्स्टिट्युट अफ मेडिकल साइन्सेस अन्डर ग्रेजुएट यता पोस्ट भएको हुनाले म चाहिँ धेरै एक्टिभिटीमा छैन भनौँ तर म न्यूरो सर्जरीदेखि बाहिर चाहिँ छैन फर्स्ट थिङ दिस इन्ट्रोडक्सन आफैको पनि बारेमा भयो अब I thoroughly enjoyed it. I'd like to thank comprehensive eloquent presentation. त्यसको लागि म पवन डाक्टर साहबलाई धेरै धन्यवाद दिन चाहन्छु फ्युचरमा अब त्यस्तो केही मबाट यस्तो प्रेजेन्ट त्यस्तो केही हुने भएछ भने दिनु म चाहिँ गरौँला स्टिल आई एम विथ यु अब सुरुदेखि नै त्यसकारण थ्यांक यू भेरी मच अब पवन डाक्टर साहबलाई त सबभन्दा lot of thanks goes to Dr. Pawan. Then Mohan सरले पनि अब he just noted me somehow. त्यसको लागि तर मैले चाहिँ सुरुदेखि नै सबै यो वेबिनारहरू हेरिराखेको छु. Thank you very much.
Thank you very much, sir, for your remark, and you have contributed significantly to development of neurosurgery in Nepal. So we are always grateful to you. You know, different generation contribute differently, but the contribution is priceless. This is how I evaluate my seniors. So Dr. Pontas doesn't seem to be here, oh? But Dr. Sultania is the second president, you know, third past president, Dr. Pontas. So any comment from other audience members? Rajiv, you want to say something about Bir Hospital, NAMS?
It was really very interesting to listen such a great presentation by Pawan sir. And history, yeah, I made many things like Dr. Damodar Parazuli. First time I'm listening his name. So many things I could knew. And regarding the history, I'm one of the privileged who worked with many Nepalese pioneers in this country. So one of who is Dr. Pawan. He was my preceptor. He was my chief. Under his supervision, I did my neurosurgery. Though I started doing neurosurgery in 2000 year, but I could do my MCH in neurosurgery in 2013 only. It was 4 years MCH program that time. Yeah, thank you very much, sir. It was a very illustrative presentation. Thank you.
Thank you, Rajiv. Yeah, depending on Dr. Damodar Parazuli, we also knew only his name. Never had a direct opportunity, as far as I remember, meeting him. But his son was the medical assistant at IOM, Dipendra Parazuli. So this is how indirectly I know him. And Achut sir and I we met in Medicare and in the forum of NESON. So this is how we know each other. About the history of neurosurgery in the private setup, that somebody has to say few words. Anybody from Amit, you want to say? Dr. Krishna will wrap up the thing, so I am not mentioning his name. So Amit, would you like to say something about how it feels like working in private medical colleges? I think it's relevant to his presentation.
Yes, actually private medical colleges came into forum because there were a lot of medical students then. As far as I remember, the first medical college to get the affiliation to run an MCS course was College of Medical Sciences, Bharatpur. And it was not the neurosurgeon, but the neurologist who was very much interested in running with the neurosurgical services. So Dr. P.V.S. Sarna should be credited with it. And he was also the program director as well as the dean of that hospital for a very long time before he left India. So Dr. P.V.S. Sarna should be actually be credited with bringing neurosurgery into medical colleges. And then slowly the practice started in Kathmandu also. Kathmandu Medical College, we started the neurosurgical department in 2012. And then in Nepal Medical College. Nepalganj Medical College was the other one which started the suit. Then it came to Biratnagar, if I'm not wrong. And then from Biratnagar, now the things have again got spread into other medical colleges in Chitwan. So the second center Chitwan started with the other Chitwan Medical College starting the neurosurgical service with Adit leading the team there. So that's how the medical colleges also started the neurosurgical education. The best part of medical colleges is that they have large number of beds to provide with. So the patients who are admitted for neurosurgical treatment, even though they are poor, they can actually afford neurosurgical services in medical colleges, where the people have still tried to cut down on the prices. of even craniotomy. So craniotomy can be performed with as less money as 25 to 30,000. So that's very, very affordable for many of the Nepalese population. So that's where I will add for the medical colleges. Well, I would like to thank once again Pawan sir. He actually made me remember my presentation. That was the one which I prepared in 2006. And the quote was the same which I started with. So thank you, sir, once again to put this thing forward. History is something very beautiful, and if in case it is narrated by those people who have lived that history, it becomes even more beautiful. And so I thank you once again on behalf of NESON as well as the whole team who has been behind this webinar for giving his precious time and arranging all this presentation. Thank you once again, sir. Back to you, Mohan.
Thank you. Okay, thank you. Neuroyam, Eastern Italian, where is he? Yam Roca, you should say something about how difficult, what are the pros and cons of working in outside Kathmandu and working in a private setup, please. Yam in the audience.
He's gone.
Hello.
He's gone.
Okay.
Hello.
Mohan.
Hello.
Hello, yes, sir. Yes, sir.
Yes, sir. Yes. Some internet problem here.
Yeah.
What was the question,
please
sir?
say something. Yes.
What was the question, please?
Yeah, how it feels like working outside Kathmandu, and you've been the one who have been working for more than 10 years, Yam, and established a very strong. Since when?
2008.
Yes, more than 12 years, and a very strong neurosurgery center in the eastern part of Nepal. Please share your experience in the context.
Yes, sir.